At this point, dear friends, it's my great pleasure and honor to invite somebody whom I hold in very high esteem because of his scholastic, his academic, his clinical and research activity. And he is no other than Professor Dr. Krishna Seshadri. Dear friends, this gentleman standing in front of you is an American board certified endocrinologist and certified long back. I tell you another thing, that he also appears and takes his test every third or fourth year he takes the test to keep himself abreast of the latest. I'm not reading that, Krishna, I'm not reading that. I'm not reading the Bible, I'm telling you one way. So he appears in the exam every year to update his knowledge. Many people will do it. Once American board or the American board, he takes the exam episodically, periodically, whenever required to keep abreast of things. He joined first the SRM Medical College in the board, and he is the person who is instrumental in establishing the Department of Endocrinology and Diabetes. He had numerous discussions with the ministry, with various people, his department. He brought in the consultants from everywhere to make the number. We need 3 + 1, 4 people. But when the center was established, he left that forum, and now he has
If we try to get rid of carbs, about a few days later, our body starts yearning for khichdi or pongal or any of the others in the morning, right? And this is what the pure studies show, that we do have one of the highest carb intakes in the world. It's not as, I will also tell you that many of our ancient foods are indeed balanced enough to introduce the amount of protein. It's just that our modern way of eating it, where instead of eating to live, we live to eat, that has made this more difficult. In my other talks and information, I would say we are the only species in the world that eats for entertainment and kills for entertainment. No other species does that. So if you notice, the idlis are made the third over the rotis, of course, are not like that. But if we see the olden ways we used to eat, the vadas have some protein in it. But we move away from it. We like our pasta, we like our pizzas. right? The important thing is that, and in fact, Sheila and I were talking, that if you look at CGMs, the greatest increase in the glucose occurs after breakfast, with carbs. Because lunch is not balanced, but your breakfast, in fact, we were talking about, if we delay the breakfast in patients, they do well. We haven't published it, but we were talking about how to get this going. And I was just reminded that my grandmother used to eat at 10:30 in the morning or 11 in the morning and then have something in the afternoon. So the further we got away, so it's not an Indian phenomenon, it's a recent Indian phenomenon for the last 100 years where we've changed our diet to become more carbohydrate oriented and more, for example, the famine that was engineered by the great British masters and butters, the adoption of potato as a staple. And indeed, there's a history to it. Because this is not very new now. So what is important to remember is that the practice has been guided in the past by Modi about 2003, published very interesting information. What he showed was at the highest level of the A1C, the greatest contribution to glucose was by the fasting sugar. At the lowest level of the A1C, the greatest contribution of postprandials is by postprandials. But in Asia, and this is a very beautiful study from China, Wang et al., showed something else. It said that how Indians or Asians respond is at the lowest level, yes, postprandial makes a very significant contribution. But at the highest level also, there's an equally important contribution by the postprandial glucose. So the postprandial is part of the total A1C spectrum across the A1Cs, right? The one caveat, whenever you look at Chinese or Japanese studies, is to remember that East Asians seem to have a greater proportion of beta cell dysfunction. The Western populations have a greater amount of insulin resistance. We probably have both of these. Right. So, what are the key problems? One is there is a higher, greater glucose excursion. What has been shown very interestingly is, let us take the same amount of cereal and give it to a Caucasian and give it to an Asian. The glucose response is much higher in the Asian group, right? And we have, yesterday Dr. Yagnik was here, and we have some very interesting, definitely a higher waist circumference. I think I'm probably one of the fitter 50s physician in this group. I can swim for an hour, I can bike for 15-20 kilometers 3 to 4 times a week. Let's see. I still have a paunch. So we have a greater waist circumference, we have higher total and visible body fat, we have hyperinsulinemia, we have higher incidence of insulin resistance. What is not so Indian but a world phenomenon is we have delayed initiation of insulin therapy. It's a world phenomenon, it's not an Indian phenomenon. People don't like insulin and we have to live with it simply because most of us doctors have used insulin as a threat than a promise, right? And it doesn't help the social media thinks that they know everything about diabetes and we don't. But because there is a need, and I showed it that across the spectrum of A1C, the postprandial has a greater contribution. So it doesn't make any sense that a basal insulin should always work. Basal insulins do work. They are very good insulins. Remember that. In the way I look at basal insulins, they are cleaner insulins. It's like you driving a small bicycle. A child is riding a bicycle. It has these trainer wheels that prevents it from falling. So there is low incidence of hypoglycemia during start. It is easy to start and build. But it does not necessarily fit everyone. And at some point of time, because of our diet, because of our failing beta cells, because of continued insulin resistance, we will require some prandial support, right? But the important thing, and this is true throughout the world, that many of us doctors think about the ideal instead of the achievable. I don't really care if all my patients are 7. I really care if my patients are able to reduce A1C by at least 1 to 2%. What we do, and this is a very Indian thing, and this is one of the few times that I agree with Amartya Sen, is that we are argumentative. We sit and constantly talk about what it could have been instead of what we can do. So, yes, patient bonus is wonderful, but will my patient take it? I'd rather have him take it something that the world doesn't think is very scientific, but he can get it achievable. So that is the philosophy. We'll come to it. What can be done? So one, you need something that is suitable for a higher carbohydrate diet. We need to address postprandial. We need to factor in all the things that contribute to the insulin inertia, and you want some kind of control. Can basal do it? Remember, yes, it can do some of it. Remember the random effect. If you control fasting, your postprandial will come down, but not always. Right? So, what can be done is what has happened since 2000 is this. We have longer acting insulins. The longer the insulins act, the lower the risk of hypoglycemia. Now, what we cannot do is to combine these long-acting insulins with other insulins to make a mixture insulin. Therefore, we need some degree of prandial support, but we want the long-acting insulin to actually be the big daddy and take care of all the other problems. Remember in the past, when you add prandial insulin, your risk of hypoglycemia goes up. But you want to do that without a greater risk of hypoglycemia. So can two different insulins within the same bottle do their job separately, but don't become a new insulin, right? If you look at the modern world, it is called cohabiting, right? As opposed to most of us who decide that we have to live with that person and procreate. But there are people who cohabit. Think of the whole populations as two different individuals living in the same bottle, doing their own things, but not necessarily influencing each other. That is IDegAsp. It is two different people. One is a long-acting insulin, another is an ultra-short-acting insulin. They are in this mixture of 70-30. They live together in the same space, and they do the same thing. I don't want to go into this thing, and all of you have seen it. But what it does is, when you have cohabitation, this hump, which is actually the problem that creates the hypoglycemia, goes away. Does this work? Let's look at this quickly. So this is an insulin-naive patient, and can you use this as a first insulin? I think so, especially if there is a big difference between the fasting and the postprandial. Many of us believe that if the difference between the fasting insulin and the postprandial insulin is more than 60 or 80, then this is one of the considerations for you to think about straight away starting with a co-formulation. You could do it on all the patients, but definitely these are the ones that you want to think about, the higher postprandial glucose. So this is a small study. People who were started on, their OADs were not touched. They were given either IDegAsp or they were given insulin touch. What do you see? As is obvious, right? When you add prandial insulin, the A1C reduction is much better. So there's a 1.4% reduction in the prandial in the A1C, which is very good. The similar with fasting glucose control. Remember, the regulator is still sitting there, and the postprandial glucose coming in. And the only time that you notice that there was not a great listing was a pre-lunch. But overall, the 7-point glucose estimation was good. And the estimated treatment difference after postprandial glucose was around 57, reducing the number of glycemic excursions. We now know the glycemic excursions are more of a problem than anything else. So when you compare IDegAsp with OD insulin, the risk of hypoglycemia is lower, remember, not statistically significant. But what is important is that 72% of patients, more patients, achieve their targets of reaching an A1C that is low and keeping it there. So this is looking at the self-measured glucose, the self-measured postprandial, and you can see the difference. This is the meta-analysis that was published last year. And of course, if you look at the time in range, right, a significantly greater amount of patients had glucoses in their time in range. This is the ARISE study, a large study with type 2 diabetes. They were given IDegAsp to the local practice in multiple countries. This was a non-interventional study. The doctor had to start IDegAsp, right, and he looked at the A1C. What did you see? So I was 188 patients from India. The A1C reductions seem to be impressive, 1.4 to 1.6, right? Second, the glucose reduction was similar, and of course postprandial. If you want to make a difference between 49 and 52, you can, but I think this is impressive stuff, right? And if there was switch in patients who are uncontrolled with basal insulin, again you will notice that the A1C reduction was greater, and these are patients who are uncontrolled on OADs. Number of hypoglycemic episodes were very low in patients with IDegAsp, and this is, and of course this is something. So what do we have? So increasingly, especially the local control guidelines are talking about using a single combination insulin, basically because it addresses our needs. You really don't want to be doing, these are patients who are working, who have families, who have lives, who need to do other things with their life. Insulin is the last thing that needs to be stopping them from having a good life. I'm not talking about the colorful ads where you have people doing big smiles. I'm talking about the patient who comes to me who is a kirana shop owner, who carries the insulin pen in his office. His wife has packed his lunch. He takes 15 minutes in the afternoon to eat. He takes his insulin through his shirt. The largest meal, 1 dose. So, simple things. Don't use insulin as a threat. Always talk to your patients and say, look, we have oral hypoglycemic agents, we also have insulin. It's the best drug that we have for diabetes. And it is not painful, it is not addictive, it doesn't cause renal dysfunction. You can take it for the rest of your life. And you know what? You can, we are there to support you. So how do we do that? Start with a simple dose. You can take it at any time, usually with the largest meal, correct? Don't have to say before breakfast. Many of my patients, I tell them, eat and dose. Because you're using a shorter insulin that works pretty much immediately. You may be serving a customer in your shop or your clinic. You don't have to take your insulin and worry if you're going to get dose. So a simple thing, especially if you're doing afternoon doses, eat and dose. Right? This is something that we work with the Delphi consensus. This is the only thing I recommend. You do not titrate the insulin. Ask the patient to titrate the insulin. What does it do? It empowers them. It gives them greater control over their diabetes. It gives them the sense of satisfaction that you're doing something about it. So in our clinic, we have a connected glucometer, where we have an electronic medical record. The patient's values flow into our EMR. And we don't do, I will tell you something, my patients aren't the super rich who do CGMs and Abbott Libres, everything. But what we have taught them is to stagger their glucose and do 1 time a day glucose every day. And we tell them take a holiday on Saturday and Sunday. But at the end of 2 months, it is already tabulated in our electronic medical record. It's tabulated in their app. And they can calculate their own time and ranges. Their time and ranges are also available. We tell them, check your sugars. If 2 times your glucose is more than 120 in the fasting, you add 2 units. So by the time they come back, they become 15, 16 or 18 units. If I start at 10 or 12. If it is less than 90, you reduce it by 2 units. Between 80 and 120, leave it where it is. When you come, I will make you jump to a few doses. But you titrate. I am not going to titrate it for you. Your son in the US is not going to titrate it for you. Your mother-in-law is not going to give you insulin. You're going to do it. You're at the mother. You know how to do it. It's you. It is your diabetes. You take care of it. And this is all that we do. So it's once a day, insulin, and you can take it once a day. Just check it once a day. If you're taking it twice a day, you do staggered. One in the morning, one the next day evening. Next day morning, next day evening. You have an average. Not ideal, but achievable. So, when should you think about it? If they don't achieve glycemic control at this point, optimal dose of OAPs, and if, for example, you're not able to push the basal dose up. Second, those whose glucose is high, and there's a difference between the fasting and the postprandial. Third, those with an increased risk of hypoglycemia, especially nocturnal hypoglycemia. Then, those who you know aren't the ones who are calling you on every glucose value, the ones who say, Dr. Mandel, 132, it should be 180. Those you can throw the basal bolus. But those who are comfortable getting an A1C of 7, you want to get their glucoses down, who have other things in the world to do, a daughter to get married, a son to take to tuition, they don't want 5-6 doses. If you do that, they will just find another doctor instead of doing what you're telling them, right? Or they may think, okay, this man I'm doing for many years, let me stay with him, but what they will do, they will not listen to you, they will not adhere. So make it simple, right? Third, also requires flexibility. Their doses vary. But some days they eat a lot during lunch, but some days they eat at dinner. These are the people who benefit from COVID. So one, high carb is what we have become for the last 120 years in India. Second, insulin is a promise, but has its limitations, right? Horses for courses. We need to tailor the therapy to the patient that we have in front of them. We have many choices of therapy. Basal plus a GLP-1 basal plus bolus. But for many of us, the comfort of a mixture or a formulation still exists in our practice because we don't take care of perfect patients, nor are we perfect doctors. We have imperfect solutions for an imperfect world. But these should get our patients to live better lives. Thank you so much.
Thank you so much, sir, for the wonderful talk and a very practical insight into it.